All right, welcome everybody. My name's Lindsay Miller. I am a 13-year papillary thyroid cancer survivor from New York. Thank you all for joining the session, either in the room here in Houston or virtually. I'm going to introduce our speaker. Dr. Sarika Rayo is an endocrinologist at Mayo Clinic in Jacksonville, Florida. Dr. Rayo received her medical degree from Southeastern University College of Osteopathic Medicine in Fort Lauderdale, Florida. She completed a residency in internal medicine at the University of Massachusetts and stayed for a fellowship with the school's Division of Endocrinology, Metabolism, and Diabetes. Dr. Rayo went on to earn the sole annual Oncologtic Endocrinology Fellowship at the University of Texas's prestigious MD Anderson Cancer Center. There, she focused on the treatment of conditions such as advanced thyroid and adrenal cancers, as well as endocrinopathies that arise from other cancers or chemotherapy. And today's session is the ABCs of papillary and follicular thyroid cancer. So thank you for being with us, Dr. Rayo.
Thank you. I'm sorry I'm not there in person. I'm also a little under the weather, so excuse me if I'm coughing a little bit. So I just, I know the audience is going to have more specific sessions on each of these topics. I'm going to kind of give a general overview of thyroid cancer, in particular papillary and follicular. I have no disclosures. So, when we think about thyroid cancer, it's kind of on the lower list of, all thyroid cancers in terms of incidence. And this is public information from the SEER website, which captures statistics on different cancers and everything. So, thyroid cancer is down here, which, so less common. Generally, it only represents about 2% of all new thyroid cancer diagnoses in the US, and generally is pretty well controlled overall. Historically, as we've used imaging more for other things, the incidence of thyroid cancer has been detected more often. So, many of you may have had like a CAT scan or, ultrasound or MRI for something else, but then they mentioned a thyroid nodule, and then you had an ultrasound followed by a biopsy, which confirmed the diagnosis. So, as imaging is just more available here in the US, you can see that the incidence has increased. But, for the past couple of years, it's sort of plateaued, and I don't want to say this is a decrease. I would say it's just more or less plateaued. And so, as I mentioned before, the survival rate or, kind of follow-up of this is very positive. Cancer-related deaths are very, very low. So overall, it's a pretty well-treatable disease. In general, when we look at gender as well as ethnicity, women have approximately a 3-to-1. I know these numbers are not exact, it kind of varies, but approximately a 3-to-1 ratio of being more commonly diagnosed with thyroid cancer with respect to men. And, the breakdown of different ethnicity types are, somewhat similar. Based on this, African Americans may be a little bit less, but the other ethnicities are quite similarly distributed. Generally, the median age of diagnosis is in the early 50s. Of course, with imaging and everything, we've identified nodules sooner, but generally in the mid 50s. And this is kind of sort of indirectly also factoring in with the staging, which we'll review later. So, I mentioned the gender, female being more at risk of developing thyroid cancer or having thyroid cancer, and age, it's generally discovered as we get older. Radiation exposure, so, in particular, head and neck external beam radiation that one may have received, you know, as a child potentially, or young adult, and which could have potentially been for other cancers of the head and neck area. Or I know, like, a lot of my patients tell me many years ago that they had some sort of skin treatment which involved radiation. So I don't know, those are, you know, specific things. You know, we talk about imaging studies, and I know a lot of patients get concerned about how many CAT scans, or, you know, even the dental x-rays that they have. You know, generally these are all pretty safe. We list this here as a risk factor, but it's really like someone who gets a lot of scans. X-ray, you know, generally has very low radiation exposure, even compared to CT scans, but, you know, CTs are not even that often given. So, and then the final radiation exposure is if one has had exposure to any power plant accidents, Chernobyl, of course, if they lived within the region of the exposure, or Japan, you know, with the nuclear accident there. And sometimes certain chemicals that people in the military may have also been exposed to. There are some hereditary conditions as well. These are not very common, but, you know, I'm just mentioning them here. I'm mentioning multiple endocrine neoplasia, but with respect to this talk with papillary and follicular, this is not related at all. It's specifically for medullary thyroid cancer, so, which I know that there will be other speakers for this, but, you know, just as a general mention. And then potentially first-degree relatives with thyroid cancer. And then when we look at the genetical part of it, you know, we talk about, I'm going to very briefly touch on the genes, but not so in depth. But we talk about oncogenes or tumor suppressor genes. So normally these, we have genes in our body that help regulate cell growth, like in a normal situation, cell growth, or also regulate cell death, you know, just as part of our cycle of cellular health. And so, but sometimes there are mutations in certain genes that may inappropriately promote cell growth. And so, you know, there's certain oncogenes that do that. So oncogene, if it's activated, then it can potentially promote cell growth. Or there are tumor suppressor genes normally that help kill off cells as in a regular manner. But if you have a mutation that inhibits that gene, then that could allow the cells to remain alive. So just kind of different things as just talking about it. So sometimes, you know, patients actually may have symptoms. It's not that common that, you know, I personally see patients coming in with symptoms and then present with thyroid cancer, but of course it can happen, and that could lead to why someone may have received imaging. So, you know, not to go into too much anatomy, but just to kind of understand why some of these symptoms exist. With radiology or any image, the left half of the screen is actually the right side of your actual neck, and then conversely, the right half of the screen is the left side of the neck. So just if your doctor reviews radiology with you, that's always important to acknowledge. This is the front of your body and the back. And as you can see here, this is the thyroid, kind of hugs right in front of the trachea, which is your windpipe here. And this is all just muscle kind of around. So around the thyroid, you know, we have these little, this is called the recurrent laryngeal nerve, helps with voice and speech, allows you to move your vocal cords. And so sometimes if the thyroid is enlarged, or if the nodule is kind of irritating that nerve, then some people may present with hoarseness. You know, of course, the trachea is there. So sometimes people may experience shortness of breath. This is very, very rare, though, that I see it. It's only in certain situations. Some patients may experience some swallowing issues. This is the esophagus that sits Really, it often more sits on the left side, but for the purpose of this picture, it sits behind the thyroid as well. And so, again, an enlargement could push on the esophagus, may feel symptoms. I mentioned the laryngeal nerve with hoarseness. And, some people, they may have some neck discomfort or referred ear pain. Now, most of these symptoms, just in general, are due to other causes, but just at presentation, something to kind of retrospectively review. There are other risk factors when someone initially has a thyroid nodule that was discovered. So we kind of talked about family history and radiation exposure. Sometimes nodules are found on PET scans, again, for other reasons. And the biopsy may have been done because the PET scan lit up in that specific area. And then if the nodule is larger, and we talked about the symptoms. So let's dive in specifically because all of you have already been diagnosed with thyroid cancer. So the anatomy or histology part is also important just to understand the differences with the cell types. So when we talk about follicular cells, there are different types. Of course, I'm only focusing on the papillary and follicular, which the guidelines are pretty similar for the management of both of them. But follicular cells are, this larger cell here, and we call this the follicle in the middle. So this would be responsible for the papillary or follicular thyroid cancer if it's abnormal. There are these other cells that sit right outside of the follicular cells. They're called C cells, or also known as parafollicular cells. Those are related to medullary thyroid cancer, which I'm not going to go into, but just to kind of explain the differences. So papillary thyroid cancer is the most common out of all the thyroid cancers, compared to even follicular. Follicular is number 2. I kind of mentioned the incidence. It's pretty similar, maybe papillary a little bit at a younger age. Diagnosis is initially found, obviously, with a biopsy and then surgery. With follicular thyroid cancer, it can be a little bit challenging to diagnose just with the biopsy alone because you really want to see, the tumor extending through the capsule. And so sometimes, with the original biopsy, you may get like an indeterminate result. And depending on, what it shows, that you may have they may recommend surgery. So, and then we'll talk about, treatment with radioactive iodine. And, if the cancer were to go anywhere outside of the thyroid, with papillary lymph nodes within the neck area, cervical lymph nodes are more common. Distant disease is rare, quite rare, but if it's going to go somewhere outside of the neck, the most common place could be the lung. Follicular thyroid cancer, of course, we see both like neck as well as distant, but if it's going to travel outside the thyroid, the prevalence of going outside of the neck is slightly higher than the lymph nodes within the neck, but of course you can see both presentations. And then with respect to staging, which we'll also kind of briefly overview in later slides, we factor in age. Gender is not factored into the staging, but we just, as I mentioned before, with the gender differences, sometimes male gender may potentially increase the risk of a recurrence potentially. We'll look at the extent of the disease after it's been removed, and of course, whether there's distant disease or not. So I don't want to go into great detail with this lower part, but this is kind of that cell picture I showed you earlier. When you diagnose either of these cancers, it's really dependent on the cell shape. And there may be description of the semoma body on the original biopsy that you had. And these are some of the different types of papillary thyroid cancer. The general management of each of these is very similar. Sometimes the subtype can just tell you potentially, you know, kind of thinking about the future, what is the risk of recurrence, with that specific subtype. But generally, the initial approach to any of these is going to be the same. And you often will not know the subtype just based on the biopsy. It's really once the thyroid has been surgically removed. And with respect to these, what we call driver mutations, so I kind of touched on the oncogenes and tumor suppressor genes. And so these are specific mutations of some of those genes. This necessarily is not required for screening at the time of a biopsy or even at the time of the diagnosis of thyroid cancer. We don't necessarily need to obtain this data. It's just usually it's obtained later, depending on if there's any differences in treatment that's needed down the line. Or sometimes you may be aware of this information up front if you had a biopsy and it showed kind of like one of those indeterminate results, and maybe your provider sent it for additional molecular testing. And so some of this data may have been captured, which told the provider that, well, this may be a risk for thyroid cancer, and then proceeded to surgery. But in general, you don't need this data up front. Okay, so, there are different thyroid cancer guidelines. These are the most common two guidelines. The American Thyroid Association, hot off the press, just published the new 2025 guidelines. The previous one was from 10 years ago, 2015. And then the NCCN also publishes or updates their guidelines annually as well. And this is a link for patients to, if they wanted to review some more information with respect to that. Going back to the nodule and, kind of what you need to do moving forward. So many times when patients present with thyroid nodules less than 1 centimeter in size, they don't always need to have a biopsy. Even if the ultrasound had shown high-risk features, we have more data now that suggests that many times these can be watched. Even if you ended up having a biopsy of a nodule within the thyroid that's less than 1 centimeter, and if it did confirm thyroid cancer, you still could consider watching it as long as it's truly confined to the thyroid and not really seen in any lymph nodes, or there's no concern of distant disease. So this is certainly an option to pursue. Also knowing the general behavior of thyroid cancer. Of course, there are always exceptions, but common things being common, this can certainly be watched. Another alternative consideration could be using alcohol ablation, where you inject alcohol or other forms. Sometimes they use radiofrequency ablation, which is involving heat, directly into the nodule that has been confirmed to be thyroid cancer. The data is relatively new with this. And not all centers offer this. It's, again, all of this really needs to be a discussion with your provider if any of this is appropriate. We do offer the alcohol ablation for some of these tiny nodules. But many times if patients, let's say their thyroid cancer was found by accident, or, unfortunately they're dealing with another cancer that may be, more involved in everything, we often tell them to hold off on doing anything with the thyroid because we can certainly closely watch it, but just kind of considering these because they can definitely have favorable outcomes, and sometimes doing too much can have negative consequences as well. So, surveillance can definitely be considered, or this less invasive approach. So if thyroid cancer, or if additional steps are pursued, then, these are kind of the general concepts that we think about. Of course, not everyone is going to have all of these, but just an overview. So with surgery, if you have a nodule that's less than 4 centimeters in size typically and confined to maybe 1/2 of the thyroid, then you don't necessarily need to remove the whole thyroid. You can just remove that half of the gland. If there's lymph node involvement, depends on where the lymph node is located. There could be a consideration more for doing a total thyroid resection, even if there are nodules on the other side. But that's also a specific discussion with your provider and surgeon, because there are some nuances with that need to be factored in. And not all patients require, preventative lymph node removal. This again will be dependent on the imaging up front. And I will, kind of mention this when you're first diagnosed with thyroid cancer, let's say surgery is going to be considered, and you've had the biopsy, it's confirmed, then you want to make sure that the entire neck is visualized on an ultrasound. Many times the report will say ultrasound thyroid, which is okay. If you have an intact thyroid, that's what our reports will say, ultrasound thyroid, but the radiologists and technicians, they do actually image the entire neck. And so that's very important to have that reviewed before when you're thinking about surgical planning. And then we'll get into the iodine and thyroid hormone. I mentioned, times when if you may consider doing just half of the thyroid. But if you've already removed half of the thyroid, or you're kind of considering at the time of surgery whether to remove the entire thyroid or not, then it's kind of dependent on some of these factors. Again, each patient will be a bit different, but so, is there known distant disease? Is the nodule or in concern, the thyroid cancer kind of extending beyond the thyroid? Is it a large nodule? When you did that complete neck ultrasound, are there lymph nodes that have been biopsy confirmed to be positive for thyroid cancer? And then, other criteria, differences with pathology or cytology at the time of the biopsy or half the thyroid removal. The radiation exposure part, it depends whether you should remove the whole thyroid or not. That's why I kind of put a question mark there. And with bilateral or nodules on both sides, let's say only one side is positive for the thyroid cancer, and the other side either appears benign or has been biopsy confirmed to be benign, you don't necessarily still need to remove the whole thyroid. You can just remove the half that has the cancer side as a possible, consideration. So this is kind of the same idea, just kind of stratified out with low, intermediate, or strong indications for surgery. The one thing I'm gonna, and I didn't go in depth with this, there's this NIFTY-P, which it used to be, it's basically like a papillary thyroid cancer, but what we call follicular variant, which is one of the subtypes, but it's what we call encapsulated. So it's within the thyroid nodule that's involved, or within the capsule of the thyroid cancer. It has not invaded into it. This is specific for papillary thyroid cancer only, and you will only really know this diagnosis once it has been surgically removed. I kind of mentioned before with follicular, which is, this one is papillary, but you need to diagnose it, you need the whole capsule to see that invasion with the follicular type. With this papillary type, you also need the whole capsule. So this is a little bit more challenging to diagnose just with the biopsy. But it's actually been downgraded to this pre-malignancy. So if this is found, this is considered a low risk for needing a total thyroid surgery. It's important to, when you are meeting with the surgeon, it's important to, that surgeon has done, is proficient in thyroid surgeries, looking at their surgical numbers and outcomes. So because, these complications can happen with any surgeon, but, someone who does these surgeries more often will reduce the risk of these issues. So of course, there's always neck tenderness, potential bleeding and swelling in the neck, but that's, true with any surgery that can occur. But, specific to thyroid surgery, going back to this picture, we have, the nerves that sit right around or right behind the thyroid. And so sometimes during the surgery, as, things are kind of getting moved around a little bit, the nerve can sometimes be just, again, agitated a little bit. So after surgery, someone may develop some hoarseness. Many times that's temporary, but depending on how extensive the surgery needed to be, then this nerve could be compromised a little bit more. But, working with your surgeon and going to an expert thyroid surgeon is important to just reduce the risk of, any impact on the nerve. But of course, the extent of disease will matter. And then I mentioned numbness because, of course, there are nerves that are in our neck area, like near skin. And so because of the incision that's needed, sometimes you may experience some numbness in that area where the surgical site was. And then we talk about calcium. So behind or around the thyroid, there are glands called parathyroid glands. They're not really in the thyroid, as this picture shows. It's really behind it. But they're parathyroid glands. They have nothing to do with the thyroid. They're just neighbors to the thyroid. So that's where para next to thyroid means. And so this risk of hypo means low parathyroid. So the risk of having low parathyroid hormone really is a little bit more increased if the entire thyroid has been removed. If only half of the gland has been removed and the other side wasn't really touched, then, all you need is one parathyroid to work. And so, patients usually don't experience any issues, which is why at our institution and, at most institutions, if a patient only has half of their gland removed, then they often can go home the same day. If it's the entire gland removed, then we typically keep patients overnight just to monitor their calcium levels to make sure it doesn't, this problem didn't occur. And many patients, after they've had their entire thyroid removed, they may just as a precaution be sent home on calcium replacement just temporarily and then eventually removed, like discontinued just in case there's a delayed finding. But again, going to an expert surgeon who, closely monitors and identifies these parathyroid glands and tries to make sure to protect the integrity of the gland is important to avoid this complication. So AJCC is American Joint Cancer Commission that essentially is the organization responsible for staging of all the cancers. So with respect to thyroid, I'm going to kind of go into these, not in great depth, but when you get the final pathology report, it's kind of extensive, some of the verbiage and everything. They kind of describe some of these specific features. And at the bottom of the report, there's often something called TNM. So TNM, what does that stand for? Tumor. So specifically the extent, size of the thyroid cancer in question within the thyroid. Nodal is if there's any lymph node involvement, and metastases is distant metastases, not involving the neck, but distant. So, not to go into great depth with this, but, when we kind of have a scoring system for each of these. So T1A, T1B is really based on the size of the nodule. There's T2, which again is based on the size or, the extent, whether it's going outside of the neck area a little bit. And T4 is for further extent of the cancer as well. Then we get into the nodal category. And oh, by the way, these T4 and T1, this doesn't mean stage 1, stage 4, or anything like that. That we'll get into, but this is just specific description of the tumor environment. So the nodal, I'm showing this picture because probably on ultrasound reports and even on the pathology, they're going to mention, lymph node levels or cervical neck levels. And so this is kind of just a nice illustration that I like to show to my patients to help identify where these nodes or lymph nodes are approximately located. So lymph nodes. And so, the most common, if it's going to involve any lymph nodes, the most common is this level 6 or 7, which is considered the central neck, which is where the thyroid is. And so if there's lymph node involvement in either of these regions, then it's N1 and then letter A. So if it's N0, N0 means that there's no lymph node involvement. N1 is there is lymph node involvement. Doesn't tell you how many, but just that there is. N1A is central neck, one of these two levels, and N1B is anywhere else in the neck area. So, this is just an illustration because you may see level 3, level 4, all of this terminology and just kind of understand approximately where it is. And then the final part of the TNM is metastases. So this is only counted as M1 if there's disease that goes outside of the neck area. And then this is with respect to the staging. And so thyroid cancer is unique where age is actually factored into the staging criteria compared to other cancers. So, once you've kind of acquired this data, determine what your T and N and M number is, then this is when you can determine the stage of the cancer. And so anyone less than the age of 55, as long as they don't have disease that has gone outside of the neck, they're all technically considered stage 1. No matter what that T-score is, they're considered stage 1. If you're older than the age of 55, then some of this nitty-gritty, T differences can make an impact and change your staging. But as long as the disease, if you're less than 55, is confined to the neck, even if it involves lymph nodes, it's considered stage 1. And this kind of is just, this is again from that SEER data showing the prevalence of, it's most commonly just confined within the thyroid, but, about 30% of patients may have lymph node involvement as well. Generally thyroid cancer is pretty well behaved, but of course, I always say that with caution because it still requires lifelong monitoring. It's just the frequency of how often that occurs can vary. But, based on the staging here, we always talk about disease survival data. And so, most patients do quite well overall, as you can see, nearly 9800% of patients with stage 1 disease are fine and live lifelong. It's one of those things that when we talk about mortality, it's, pass away with it, but not from it. So that's kind of a good thing with this cancer. But again, we always consider everything and follow it very closely. So that's the surgical part and how we stage it initially. Now let's talk to the radioactive iodine, because not all patients actually need this. This is in a select patients based on their imaging and pathology criteria, but that's a discussion with your doctor. The new guidelines have what we call like risk of recurrence based on the pathology, and from that can help guide decisions whether to pursue radioactive iodine. But just to kind of explain what this is and why are we even considering it. So I have a slide right after this that may be a little bit simple to understand, but on the thyroid cell, remember those follicular cells that I showed before, on the outer wall, there's this sodium iodine symporter or sodium iodine channel. And that basically brings sodium and iodine together into the cell, which allows the cell to function and produce hormone and regulate itself. So we use the concept of this channel with respect to radioactive iodine. So radioactive iodine it's a nuclear form of regular iodine, and its goal is to try and trick the thyroid cells into still taking it up. So we use this radioactive form, which is called I-131, and the cells, take up this iodine, and the goal is to kill the remnant thyroid cells that are there. So, who do we consider this in? Well, patients who have only had half of the thyroid removed. Sorry, I didn't include the, kind of the little nitty-gritty descriptions here, but essentially those who've had half of their thyroid removed do not need this for sure, because, they already have low risk of disease recurrence. So, you didn't already pursue the whole thyroid to be removed. So there's no need to give it in those patients, because if you give it, then you're going to kill off the other half of the thyroid, and there's no purpose in that. And even if you've had the whole thyroid removed, it really will depend on the pathology, how large the disease is, how many lymph nodes are involved. Just because you have lymph nodes involved, that doesn't equal you requiring radioactive iodine, but it's factored into the decision making. And then, if there's any concern of distant disease involvement as well. And this is, again, very specific for papillary and follicular thyroid cancer. With the other thyroid cancers, it's not necessarily needed. Oncocytic, which I believe there's a discussion on, it's sort of debatable, but I'm not going to get into that debate right now. But, with papillary and follicular, this is the only time when you would even consider using this. Typically, the radioactive iodine is in the form of a pill, and it doesn't work immediately. It takes several months, maybe up to a year, for it to fully kind of kill off those remnant thyroid cells, but it is still working in your system. ThyCa, has information on the low iodine diet, and of course, very detailed information on all of the thyroid cancers as well. But kind of when you're thinking about preparation for radioactive iodine, we recommend a low iodine diet for 2 weeks. And so patients tell me this is the worst part of their treatment course, because it's very difficult to find foods that are low in iodine. It's a healthy diet, but it's a very clean diet, but it could potentially be bland as well. But I just want to kind of highlight some things that are important even to consider with that, bland part of it. But iodine is used in a lot of preservatives. So the ThyCa website, as well as the American Thyroid Association, has some information on what foods are okay to eat, what to avoid, how to read the nutrition labels, and even a recipe low iodine cookbook. And the reason why we do this low iodine, and this is only purely for preparing for radioactive iodine, it is not needed for management and the follow-up of your thyroid cancer outside of this. So if you're not doing radioactive iodine, don't need to worry about all these iodine issues. It's perfectly safe otherwise. But the reason why for this specific treatment we do the low iodine diet is because, as I showed before, the thyroid cells, they take up iodine to help it work and function. And so we use that concept to try and starve thyroid cells of the iodine as best as possible, so that when we give the radioactive form, it is more likely to, kind of actively take it up to kind of get the best benefit. The other thing that we do there's a protocol that we use. So the 2 weeks before, you'll do the low iodine diet. And then we have a protocol where, patients come on different days of the week, and get lab work, and also get an injection called Thyrogen. So in the next couple slides, I'm going to go into the TSH and what that means and everything. But Thyrogen is an artificial form of TSH, and it stimulates the thyroid cells to take up that iodine better. So it's a short-acting medication. Depending on the protocol that we're using, it requires multiple injections because it's short-acting, and you just want to make sure that the effect is there while you're giving the radioactive iodine. So I kind of like to think of it as a two-hit process with the thyroid cells. So you've starved the cells of iodine, and you're also stimulating the cells to help it better take up that iodine. And then we also will do a whole body nuclear medicine scan. This can be done at the time of when you're planning your radioactive iodine dose as well. And we often do it 1 week after the treatment because we want to kind of get an idea or lay of the land of where all of that iodine was taken up. The dose of the radioactive iodine it's sort of arbitrary, but sort of not. There's no like, if you have this much disease, this is how much you need to give. There's no calculator per se, but it really depends on the extent of disease, at the time of the surgery, and then the dose will be determined. Sometimes low dose is given if for whatever reason the patient really would like to get radioactive iodine, maybe not necessarily needed, but still wishes to get it, then, we can give a low dose. But the dosing varies, and there are different types of radioactive iodine protocols as well that each institution may have. I didn't mention the other protocol for how to do this. So Thyrogen is what we often will do so that the patient is allowed to stay on their thyroid hormone medication after surgery. Before, there used to be what is called as thyroid hormone withdrawal, and sometimes it's still pursued, but it's not necessarily more effective than this. But in the thyroid hormone withdrawal, patients need to hold their thyroid medication for a couple weeks leading up to this to help raise their TSH. I'll kind of explain that whole TSH concept in the next slide, but to raise the TSH naturally, if you will. But when you don't have thyroid hormone, symptoms can kind of creep up with hypothyroidism. So we don't like to use that process as much. We usually prefer Thyrogen because it's quicker and you can stay on your medication the whole time. And so this is the other thing with radioactive iodine. So this is only after you have received a treatment form of radioactive iodine. Sometimes we do what is called as a diagnostic scan, which uses a different chemical. It's called I-123, but it uses a different chemical, and that's just purely to take a picture of, where these thyroid cells could be in your body. Of course, if you still have your thyroid or half the thyroid, you wouldn't even be doing this, but there would be uptake in that area. But this isolation precaution is not needed if you're just purely taking a picture. It's only if you've received treatment, which is the I-131. And so this is from the American Thyroid Association, and just some guidelines or thought in terms of planning when one would do the radioactive iodine with vacation or different events coming up, because there's an isolation precaution. You're considered more radioactive, meaning you're emitting that radioiodine activity out. And so there could be a risk of other people near you or pets impacting their thyroid function. That's really what the problem is with it. And that's why we try to maintain the distance and separation. Brief interactions, is okay. I work at Mayo Clinic, and so we get a lot of patients who do not live in Jacksonville. They live further away. So if they're coming with someone else driving here, we tell them you need to stay, drive separately, or, maybe they stay locally in Jacksonville for subsequent appointments afterwards. So, and then there's other, specifics with contamination with utensils. So we usually use disposable utensils and then dispose it in a specific way. Generally, radioactive iodine is pretty safe, but if we talk about risks involved, some people may develop a little bit of nausea, but the risk that we usually talk about is involving the salivary glands. So the iodine is taken up from the thyroid cells, as well as and thyroid cells, in the neck or anywhere in the body if it happens to go there. But it's also taken up by the salivary glands. So we have 3 pairs of salivary glands in the neck, which of course produces saliva. And then of course it's physiologically taken up in other places too normally. But part of, after you receive the radioactive iodine, it's important to hydrate. And, we talk about eating like sour foods or sour candies to help kind of stimulate the salivary glands to expel that radioactive iodine to kind of reduce the risk of any potential damage. But, if it could be temporary with dry mouth or taste issues, sometimes the effects can be a little bit more prolonged. Before giving radioactive iodine, we recommend to patients making sure that they've had, they're up to date with their dental work and dental cleaning, and then kind of maintain that dental health even afterwards, because saliva is, of course, important to maintain our oral health overall. So, we usually talk about that. The reproductive delay is, I put a question mark here. It's not widely proven. The one thing that we do 100% say is a women of childbearing age, we typically, if they do receive radioactive iodine, we do recommend that they hold off on getting pregnant for about a year. I know some places they say 6 months, but we typically recommend a year, just again to make sure that the baby doesn't get exposed to the iodine. And then, of course, also refraining from any breastfeeding as well. Even if you get the diagnostic scan, you don't want to get the diagnostic scan when you're pregnant or breastfeeding. And then especially iodine treatment, you want to delay pregnancy for about a year. But actually causing problems with getting pregnant eventually, that's what I mean with the question mark. It's not been widely proven. And then the secondary malignancy, this is like more with respect to blood disorders. This is very rare, but the risk can increase if someone, receives very, very high doses of radioactive iodine cumulatively over time. So we talk about this, but it's not, not always, not as much of a concern. And then these are, if someone has had surgery or radioactive iodine, this is kind of what we think about as we're monitoring the patient with imaging and tumor markers, which I'll get to. So thyroid hormone, this is an important concept with the TSH, because the TSH is always a little bit of a confusing thing. So TSH is an acronym. It stands for thyroid stimulating hormone, and it does exactly that. It's made in a gland called the pituitary gland, which sits at the base of the brain. And the pituitary is scanning how much thyroid hormone is in the body at all times. It doesn't know whether you have a thyroid or not. It's just scanning how much hormone is there. So, if the pituitary senses that there's less thyroid hormone for whatever reason, its job is to stimulate the thyroid to make hormone. Of course, now you don't have let's say you only have half the thyroid left, or if you don't have the thyroid at all, some patients do require, all patients with the entire thyroid do require hormone replacement. Half the thyroid, it depends on, your production. And so we give thyroid hormone replacement, specifically T4. T4 is the main hormone made from the thyroid, and this is considered the inactive thyroid hormone. and it gets converted to this active thyroid hormone T3 in different parts of our body. So all you need is the T4, which, these are the different brands. Levothyroxine is the generic form of all of these. And then there are some other brands that are also available out there. You don't need to replace the T3, the active thyroid hormone, because this is going to be converted from your T4 in other parts of the body. Sometimes T3 is given based on symptoms later, but it's certainly not required. So let's say, just kind of to explain this concept with what TSH means and why we think about TSH goals. So if you did not have, your thyroid, let's say your whole thyroid has been removed and you did not take any levothyroxine or any thyroid medication, your pituitary is going to sense that, okay, there's not enough thyroid hormone present here. I need to stimulate something to make thyroid hormone. And so there's obviously no thyroid gland. There could be remnant thyroid cells that are there, benign or malignant. And so it's going to release more TSH to try and stimulate those cells to make hormone. It will not be successful because there aren't enough cells. But if you do not have enough thyroid hormone, the levothyroxine, you will see a high TSH. So it's important when you see the labs and everything, a high TSH just means there's less thyroid hormone. It doesn't really have to do with cancer per se, but it's just reflecting how much hormone there is. But when we do think about the cancer side, we want to make sure that any remnant cells that exist there are not being aggressively stimulated. So the dose of how much thyroid hormone one receives is going to be dependent on kind of the response with the surgery, and if they receive radioactive iodine, or if there's any concern of ongoing remnant disease. And so we have, these different targets that we use. It's not, 100% that you have to follow this exactly. This is just maybe a starting point to think about. If someone had achieved very good response, there's no concern for recurrent disease, or they only had half the thyroid gland removed, then really your TSH level can be just normal is your target. But based on whether there's structural concern or biochemical, this thyroglobulin is a protein that is normally made from thyroid cells. And so in the absence of your thyroid, completely absence of the thyroid, you won't have the thyroglobulin anymore. But if it persists, then there could be evidence of, some thyroid cells that are still present. So we may increase the amount of thyroid hormone in an effort to lower the TSH. So if we have too much thyroid hormone and more thyroid hormone in our body, then the signal is sent to the pituitary. Pituitary says, okay, well, now there's so much hormone here. I don't need to stimulate the thyroid cells to make any hormone or do anything. So I don't have to, my levels can be low. And so this is known as hyperthyroidism. So when you talk about low and high levels, that it's important to understand like what is low and high thyroid, this TSH or actual thyroid hormone, because the TSH is just the regulator of the thyroid. And then there are other factors that we always consider, because if we do make someone hyperthyroid, then it can increase your heart rate, impact the bone, maybe cause irregular heart rhythm like atrial fibrillation, and then we also consider the age. So, and then other symptoms as well that patients may experience, because quality of life is equally as important as all of this. So then when we just are considering following the patient after they've had their whatever treatment, whether it's surveillance or they've had surgery, partial or total, whether they've received radioactive iodine or not, then I kind of think about three concepts moving forward. So what was their initial stage of diagnosis? Did they have any iodine? But what does the imaging show moving forward? And again, we need to image the entire neck area, very comprehensive analysis of that, just to make sure we assess those lymph nodes. So ultrasound is important with the follow-up. The other imaging, CAT scans or PET scans or whatever, this is only really if you're concerned about disease that has gone outside of the neck. So, we're following this thing called thyroglobulin, which is a protein normally made from thyroid cells. I have my thyroid still intact, therefore my thyroglobulin will be present, and that's not abnormal. That's supposed to be there. If you have half the thyroid, you will still be producing thyroglobulin. So, but in someone who does not have their thyroid anymore, and we're following this tumor marker, and we're imaging the neck area because that's what we should be imaging. But let's say we don't see anything, but the thyroglobulin number kind of keeps going up quite a bit. If it's low, it's okay, but if it's going up pretty high, then your doctor may consider start imaging outside of the neck area. Could include a CAT scan of your chest or something else, but there are a lot of factors. It's not that common that it does go outside of the neck. And then the other thing are any clinical findings that as I'm kind of monitoring these patients. So in case I need to do something further. And then that's the last slide, but the interval of follow-up with these patients will be dependent on all of this, as well as their original the original pathology, as well as iodine and everything up front. So I may see them initially at 6 months or a year, depending on what I see in the beginning, and then if things look okay, then may decrease the frequency of my evaluation, not after the first year, but maybe after a couple years, or or see them more often if I see a change in something. So that is going to be dependent on a lot of different factors, as well as the comfort level of the provider and the patient. So that's kind of my overview. I know.
Why do we make sure the entire neck is ultrasounded prior to surgery?
Okay, good question. So, usually let's say the nodule is found by accident through some other imaging, and then, you've confirmed that it is thyroid cancer. What you want to make sure is you want to view the entire neck area to make sure that there are no lymph nodes that appear suspicious. Because if you're operating on someone, then if there's a lymph node that looks concerning, you're already operating on the neck, you might as well address the lymph node, or you should address the lymph node at that time. So I receive a lot of patients sometimes where they've just had purely thyroid ultrasound. And again, the title of the report may say ultrasound thyroid. That's okay, but you just want to make sure that the technician has indeed visualized the entire neck. So for that surgical planning.
I know this is an ongoing, lifelong thing where you have to keep searching, but if you're like 5 years out, would it just be like once a year? Would you recommend?
It could be once a year, even in the beginning. If you have very low disease risk of recurrence, it could be in the beginning where it's once a year. We kind of use the 5-year mark as if someone has achieved remission, full remission, then the frequency can certainly decrease. There isn't really hard guidelines on what that frequency necessarily is, but it is lifelong follow-up, yes.
Quick question. So going back to what you're saying about TSH, how frequently do you see people who had no heart problems or, and don't have any structural issues with their heart go into AFib? As I guess, kind of to build on that, how often do you see it in younger patients? So like under 35?
Where they develop heart issues.
Where they have an arrhythmia, like while they're adjusting the medicine after a total thyroidectomy.
I don't see, with younger patients, I don't see the arrhythmia as often. The only thing I'll see is the fast heart rate. And, if it's a little bit fast, it's okay. You always think about the risk versus benefit of, what you're doing with thyroid hormone replacement. I think with younger patients, if I were to make them hyperthyroid, the greatest symptom that people tell me is actually fatigue. Because being
Anxiety too.
hyperthyroid, huh?
Anxiety
Sorry?
too. In my case, it was anxiety, and then I had AFib with RVR.
Exactly.
My
Exactly.
TSH was
Yes.
like 0.1, 0.01.
Yes, yes. So anxiety or mood changes, irritability, and fatigue are really the more common symptoms I see, more than the heart rate issue, um, is really what I see. And then, obviously, if I'm comfortable watching and adjusting their thyroid, I want them to be, live a quality life. I'm not going to strictly go by this and, because these are just a starting point. So I do reduce the dose, and it's important to understand, like with the fatigue aspect, I think it's often a misnomer where if you have more thyroid hormone, that means you have more energy, but that's not always true. I've had several patients where they're hyperthyroid, they feel more exhausted and everything, and maybe they're very hyperthyroid, and we've lowered the dose a bit, and they actually feel better. So it's just important to kind of understand that part of it as well. But yes, to your point, I see more anxiety and mood changes and fatigue than really the fast heart rate.
What is the time frame following thyroidectomy before starting radioactive iodine?
You want to you want to let the surgical bed kind of heal itself. So I usually wait, a month or so at the earliest if I'm going to do it. But it doesn't necessarily have to be a month. You can always choose to give, if you're not giving radioactive iodine up front, it can always be given later. It's not like a one and done thing where if you didn't give it in the beginning, then you can't ever take it. So there's no rush to it, but I usually wait at least a month.